Welcome back to Quick Hits, the podcast where we explore the latest trends and innovations in healthcare technology. I'm your host, Tyler Smith, joined as always by Ken Booth. Today, we're excited to bring you a truly inspiring guest, Khalid Turk, the Chief Health Information Officer at the County of Santa Clara. Khalid brings over 2 decades of experience in healthcare IT, having started his journey as a software engineer before rising to lead one of the largest public sector health systems in California. During our conversation, he shares his incredible story, including the pivotal moments that shaped his career, such as helping integrate 2 hospital systems in just 5 months, a feat that many deemed impossible. Khalid also dives into how his team balances innovation with resource constraints, ensuring equity and accessibility in digital transformation projects. From leveraging AI to streamline patient care to navigating the unique challenges of serving a diverse population, Khalid offers valuable insights for anyone passionate about healthcare technology. We're thrilled to have Khalid on the show to share his journey, his strategies for overcoming challenges, and his vision for the future of healthcare IT. Don't forget to follow us on your favorite podcast platform and enjoy this episode of Quick Hits.
Another episode of Quick Hits. I'm your host, Ken Booth, joined as always by my co-host, Tyler Smith. Tyler, how are you today?
Absolutely thrilled to be here, Ken.
Yeah, same. Today we have a special guest. We are talking to Khalid Turk. He is the Chief Health Information Officer at the County of Santa Clara. Khalid, how are you today?
I'm good. Thank you. Thank you for having me.
Yeah, absolutely. Thank you so much for joining us on Quick Hits. We love having conversations with individuals such as yourself with your great background, which we really want to get into. So before we start with some of the questions about where we're headed in the future, we always like to get an idea of where you've been in the past. So can you give us just a quick synopsis of your career and how you ended up as the CHIO?
Yeah, great question. Hi again. My name is Khalid Turk. I work as Chief Healthcare Information Technology Officer at the County of Santa Clara, which is located here in the beautiful Bay Area, close to San Francisco. Our headquarters is here in San Jose. What we do here is that just to give listeners a context before we actually talk about my past, is that County of Santa Clara has one of the largest public sector health system that comprises of 3 hospitals, over 20 clinics, the whole behavioral health system department, and also public health care. So we are one of the largest. How I got this job? I've been in healthcare for over 20 years. Started as a software engineer, went through different iterations like software engineering to team lead to project manager. And for almost 10 years, I worked as an independent consultant focused on implementing Epic EMR. And with that, I had opportunity to work at multiple organizations, large and small, till I started working as a consultant here at the County of Santa Clara when they started their EMR journey by implementing Epic in 2013. And during that time, I got multiple opportunities to help County of Santa Clara to implement EMR, optimize EMR, and take on to multiple digital transformation initiatives. So it happened that in 2018, County of Santa Clara acquired 2 new hospitals, the O'Connor Hospital, which is part of our system now, and the St. Louis Hospital, which is also part of the system. With that, our capacity increased from 700 beds to 1,150 beds. And that was one of the challenging projects. We were given a very short-term timeline, about 5 months, to integrate those 2 hospitals, which were running on age-old systems, to bring them on the county systems as well as our flagship EMR, Epic EMR. And that seemed like impossible. But I was lucky enough to have that opportunity, and also lucky enough to have a wonderful team that actually got us over the finish line and in a successful way. Once that project was done, which was mission impossible at some point in time, I was noticed by the leadership here at the county. And when this opportunity came up of the appointing a chief healthcare information officer in June of 2020, we were going through the pandemic and there was a leadership need. So they offered me a job, which I graciously, happily took it. And because I've been serving this county prior to that as a consultant for multiple years. I truly believe in the mission of the county, which is to provide healthcare to anybody that would not be able to afford healthcare on their own. So we are a safety net organization. We are mission driven. Everybody that comes to the healthcare system here at the County of Santa Clara comes with a mission to provide the best care that we can. And that really enticed me to take this job. And I've never looked back and had any other thoughts. So I'm glad to be here.
Wow, what a great mission. That's awesome. And if I could just clarify for our listeners, because I think I misheard, you did say 5 months to do that implementation, right? And that was 2 systems?
Yeah, 2 hospital systems,
Wow.
and multiple systems actually. There were only over 30 applications, but there were two fully functioning hospital systems. Yeah, we got the keys to the hospitals on March 1st, and we had the marching orders to bring them over to our systems by August 18th, which we did.
Wow.
Same year.
That kind of takes us to our first question. So in a situation like that, what was your strategy in navigating such a unique and really impossible challenge? You mentioned your team, but can you dive into the strategies and the mindset that you had when you went into that?
Yeah, I'm glad that you used the word mindset. To me, mindset and attitude is the most important trait when I'm building my team. So I looked around me, what resources we have, whether working within our team already or we have to bring it from the market. We wanted to bring in people who really are not limited by the frameworks and the other methodologies like whatever PMI would tell you or PMP tell you or even Agile tell you. My approach always have been, and almost 20 years I've done software implementations of small and large scale, is that if you have the mindset to achieve a target, then you'll find a ways to do that.
Mm-hmm.
And that's the first speech I had with my team, that, if you look at the um, typical software development lifecycle or system development lifecycle, you will start with the requirements and then you get bogged down by, I have to do the charter, I have to do the kickoff, I have to do the installation and testing and whatnot. All of those steps are very, very important. But the beauty of digital transformation is that we need to do it, what needs to happen, and then see that where we can bring in synergies and other techniques to make it happen. For example, this concept of MVP, minimum viable product, is age old. And can we apply to some of the systems? What is the best minimum that we can do without harming a patient and while not hindering the care providers from providing the care? If you bring in the system, even if it's a top notch, but it adds additional steps to the care provider or in some way harms the patient, obviously, even if it's a cutting edge, it's not the best solution. So we were looking at what is the minimum possible. For example, if you have to bring a lot of data that needs to be converted, what data and why we are converting that, whether it's to complete the legal medical record, LMR, is it for the continuity of care, or it's just for the release of information, and what are the other reasons we are converting that data. So we have to make sure that we have what is essential for day one, and then we continued on beyond August of 2019 to make it happen. So in that regard, my strategy is going to be that people who believe that things can happen, targets could be achieved no matter how difficult they are. Nothing is impossible, and it's not like a pep talk. Literally, if we set up our mind on something, we can really achieve that. So it was having the right people in place, having the correct scope in mind. If you start boiling the ocean, obviously you need tens or millions of years. But if you think that at some time a bucket of water would work, so you work with the bucket of water. So that was basically my approach.
So from that process, I mean, that kind of led to you being a leader in digital transformation. What were some of your greatest lessons learned then? I mean, you mentioned a few, but if you could kind of distill it down to just a bullet point list, what's the most effective way of navigating the unique struggles in healthcare today that you still have carried on? And maybe what are some things that you wish that you would have done better?
That's an interesting question. So many things come to my mind based on my past 24 years or so of experience in healthcare. But if I distill that, one is that it's very, very important to have clear communication to the stakeholders, and clear communication to your team those who actually make the transformation happen, the change happen. So from the stakeholder perspective, we need to understand it's a two-way communication. It's not just telling them, also listening to them, that if they are proposing a change, and the change could be implementing a new system or acquiring a new hospital and merging that, what is the core purpose of that? Once you understand that very clearly, you can articulate the scope that needs to be achieved through your team. So it's important that you understand the why of the change and also translate that why in clear terms to the team who's actually working on the tools and technology to implement that, to configure it, to test it, and make it production ready. So communication is definitely number one aspect of any change, any implementation, any transformation. Additionally, what I can think that when some challenge or problem is shared with you, you have to look from a different angle. Even if the why is clear, the what is not always clear, or how is not always clear. That the change could be that we're going to expand our services by acquiring another hospital. That would be the why. The why is that service needs to be expanded. But how are we going to do that? And what we will acquire in this case, and how we're going to acquire, those are the details that needs to be discussed further. And in that process, you actually define what is the minimum possible that could be done in a given time. Because every job, every task that we do, it has a typical constraints, as we will call it. There'll be limited resources all the time. There'll be some deadline associated with that, and there'll be limited human resources also available. So given those situations, what is the best could be done? So the initial response is, it's not possible, which is not acceptable to the business. And I am with business on that one, that, yeah, that should not be acceptable. IT
Right.
exists to solve the problems, not to tell the stakeholders that this cannot be done. So how it can be done, that will be the next learning exercise that I had in my experience. But now when any problem comes my way for the transformation or organizational change or the system change, I'll see that I understand your why, but can we negotiate on how and what? And sometimes business is willing to, or most of the times actually willing to do that. And then you can say that, yeah, it is what you're trying to do could be like 2 year long project or initiative. Let's break it down. Maybe we can do it in 6 months. And at 6 months end, you will have these capabilities. The next 6 months beyond that will have additional capabilities. But the end of 2 years, you will have the full transformation that you are expecting. So it's a two-way communication between the stakeholders and you as a leader, whether you are just a simple project manager or you are an organizational leader, to understand that why something is being done, but the what and how need to be negotiated. So you come up with a plan and a scope that could be delivered in time. Other than that, you can apply any of the frameworks that you say that, this is how the quality will be introduced. This is how the process change management will be managed and other things. There are so many things that come to my mind, but it's important. The communication is really the key. Another one is that the why, the what, and how need to be very clear.
Khalid, really love your approach on making it happen. That's actually our brand essence at HDM, and also your point around mindset. One of our values is growth mindset, and couldn't agree with you more about how important attitude is. So I've got some assumptions based upon what you said around chunking work, breaking it into the simplest possible segments, if you will. But if we're looking at M&A and specifically the challenges in consolidating data from disparate systems, when we're talking about M&A, how do you approach standardizing and harmonizing data across organizations?
Yeah, data is anything that is associated with data will always be challenging. And it's challenging not because of the technology, because of some of the external factors to the technology, for example, legal and compliance. So when it comes to standardization of the data, in large complex organization like County of Santa Clara, or typically any other county, health system is not the only system that is generating healthcare data. And on top of that, the other entities within the county might be interested in your healthcare data. So when you look at actually standardization of the data, you have to make sure that whatever you do is actually compliant, and it's also follows whatever the legal obligations the organization may have. Just to give you a quick example that where this compliance and legal is coming from. When we talk about compliance in healthcare, obviously everybody talks about HIPAA. In some cases, when you're talking about the behavioral health data, then we talk about 42 CFR Part 2, which is very stringent regulation, which guards especially the substance use treatment and other mental issues, because those two data in most of the cases cannot be mingled together. So that's another challenge, maybe for another conversation. But what I was trying to clarify here, that before you standardize, you have to make sure that the standardization at the end is going to be compliant, not only very well-known rules like HIPAA, but also some of the more complex and niche rules like 42 CFR Part 2. 42 CFR Part 2 dictates that the substance use treatment data cannot be shared with even the care providers, even if they are personal care providers, PCPs, unless there is an explicit consent from the patient. And many patients who are in substance use treatment, probably they're not even in a state to understand the consequences one way or the other. So it's very likely, when we have done some surveys where those patients were not willing for their data to be shared. So the point that I want to highlight, that before standardization, again, the why needs to be there, that why we are standardizing data, and whether it's for some legal or compliance reasons, or it's actually for the patient care reasons. And when it's the patient care reasons, it is contrary to the common sense, but sometimes we have to follow the rules. Even it would be better for a patient to expose their data to their care providers, but because of 42 CFR Part 2, we cannot do that. So now we're coming to the nuts and bolts of that. What data is being acquired? Nuts and bolts of the question that you ask, how it needs to be standardized, or what data is needed, why it's needed, what are the sources, what are the targets. And then we have to see that what standardization are benchmarks that are being used on the target system. I'll make a very quick here example that will make sense. When we acquired O'Connor in St. Louis in 2018 and 19, it was a year that crossed over. We had to bring the patient data, or PHI as we'd called, into our system, which is a typical function, or the first function after the merger happens. You have to look at the acquired hospital and bring their data, patient data, and they were close to 2 million records. Our system, by virtue of implementing our means County of Santa Clara before merger, went through multiple iterations of cleanup and MRN duplicates, which is a typical artifact of any healthcare organization, any EMR, but at the lowest, which is industry acceptance rate, is only 3%. More than 3% duplication rate is always thought to be harmful to the patient, and we brought it there. But right after the acquisition, our rate went to over 7%, a little over double actually, which is not really the ideal state to be in, because the initial step was to bring the patient data and merge it. And then we have to go to the standardization. In the standardization, we have to take our parameters, that how to reduce duplicates in the data. I'm just making one example, which is like patient health information, like PHI, the like patient name, date of birth, what we call demographics, maybe their address, maybe their other identifiers. And we have to go through this standardization process, just make sure that when these parameters are met, it's likely that the data which is recorded in two different records is actually belonging to the same patient. And these are very stringent guidelines. There are about 40 different parameters that are looked into to make sure that this information is duplicate, and it is needs to be merged together. So we went through this process for the PHI data. Now that we are acquiring another hospital, we are gearing up to go through the same process again. So that was just one example, but similar example will apply to the lab data, to the radiology data, in pharmacy data. So when we look at the data, the typical data that is migrated from the source system, which will be the system of the acquired hospital, to the target system, in our case is always Epic, because we have been doing Epic since 2013. It will be that what is the core data that needs to be brought in. Like in generally, we bring the patient demographics, we bring their problem list, we bring their medications, We bring some of the critical lab data, which is time bound. Like, I don't want the lab result, not me, but my providers don't want the result, which is 5 years old, but 2 years old is relevant. So based on those parameters, we look through the source data, we organize it in a way that could be consumed or ingested in our target system. Sometimes we use HL7, so we will, in some cases, bring the data via HL7. In other cases, we can ingest directly into the database of our EMR. So these are the approaches that I take. I hope I addressed your question, unless you're asking something else.
No, this is, great. And it really is eye opening when we talk about the different challenges faced by public sector versus more public facing systems, municipal systems like County of Santa Clara versus, typical nonprofits and academic medical centers and also the for profits. It'd be great to hear like areas where you've used really innovative approaches that are unique to the public sector that you've been able to implement at the County of Santa Clara to overcome challenges.
Yeah, that's a very interesting question. Where we live is one of the richest area in the world, not just United States. The San Francisco Bay Area, with every other tech giant headquartered here, and a lot of startups happening. And we are so lucky to have so many established healthcare organizations, like within where I stand here in the San Jose. Within, I would say, 10 to 15 miles, I would have Stanford, I would have Kaiser, I would have Sutter Health, I will have El Camino. There are so many. HC hospitals are here. So there are so many organizations, and most of them are private organizations. So they have definitely access to many more resources. And for us, even though we are a safety net organization, obviously we have to generate revenue on the care that we provide to continue to serve the same population so we can stay solvent and in business. And in order to do that, we cannot compromise the services that healthcare organizations only 5 miles away from me offer. For example, if they have a certain EMR, we need to have that certain EMR. If they have a patient service portal, we need to have a patient service portal. If they have some communication protocol for their patients that they can call their providers anytime, we need to have that. So where there's a huge disparity between the resources, like a very well established, respected, and rich organization like Stanford Healthcare has versus us, it becomes a challenge. So we definitely have to prioritize where we want to invest in, and that continues to be a challenge. But what we have done with the help of the overall leadership on the health system on the county, and we are governed by the publicly elected officials. So through their help and their support, we are able to prioritize the initiatives that will actually keep us at par, and in some areas actually better than that. Like our trauma center is one of the best in California, and also one of the top in the whole country. And our rehab department is #1 in California. So we are, even with the limited resources, some of the best healthcare services providers in some cases in the country, and another definitely in California. So how we do that? We have to make sure that we have to invest in our resources to make sure that they have the right skill sets. And as I talked about, right attitude anyway, because all of us are mission driven. So when every day we come here, we know that who we are competing with. And we also know that who we are serving, especially the underserved population that cannot get the services that these top-notch healthcare organizations are going to provide. So in that regard, we make a focused effort to bring in the technology that can really help the patient to bridge that gap. That is one side of the equation. Other side of the equation is knowing your population that you are serving. We don't invest unnecessarily in the technologies where the impact is going to be lower. Just to elaborate a little bit more on that one, for example, like we live and serve the community, live in and serve the community that has people from literally every country of the world. More than 60 languages are spoken in the county of Santa Clara. And our population also, the majority of patient populations speak multiple languages. Our main languages are not only English, but Spanish, Chinese, Vietnamese, Hindi, and many other variations. So when we think about implementing a technology that either is contributing to the patient care or is helping our care providers to gain efficiency in providing care and be able to see more patients in the given time, we have to make sure that actually serves our population. On top of that, some of the population we serve, they don't even have a roof over their head. A lot of homeless population, in this state and in this county. So we have to make sure that we don't overly invest in a technology that cannot be consumed by the population that we intend to serve, whether they don't have access to the technology or they have some other barriers like the language barriers or the cultural barriers. So we are very diligent about very well understanding our population very well, understanding the potential of the technology, and making sure that we do the right choices because we have limited resources, that only implement the technology and technology solutions that can really serve our population very well.
Really fascinating to listen to how you're in this incredible cohort. You're in this, like you said, one of the wealthiest areas of the world, and yet you have constrained resources. The way it seems like your guiding principles are serving your patient population as they should be, and you have to really know the patient population. So probably some fascinating case study that could be done on how Santa Clara, yet sitting amongst the Stanfords and the UCSFs, and still adopts the technology and the processes that keep it world class while serving a different patient population. And it kind of leads me to the next question about, you said you do this, but I'm interested a little bit more in that, like how you approach ensuring equity and accessibility in your digital transformation projects, so you ensure that your initiatives don't widen gaps in care.
Thank you. Thank you for recognizing that. I really appreciate it. This is what keeps us coming back to work every day and keeps us excited for the job we do. So the equity in the healthcare is an issue everywhere. It's not just the county of Santa Clara. But our issues are unique. As I was saying, that our population speaks more than 60 languages. Literally, that's a lot. And they also come from different parts of the world, different cultures. So our job is to make sure that technology is accessible. Every organization that has implemented ERs since 2008 have definitely seen improved outcomes from the care, not only the care when they are admitted, but also preventative care. So what we are trying to do is to make sure that our healthcare stays mobile where it's needed. I'll give you a good example from the pandemic. When the pandemic happened, we had converted literally every space that was out here into larger space would be in the vaccination. I'm not far away where I'm speaking from now, from my office, from the 49ers Stadium, which is here in Santa Clara. And 49ers Stadium, we converted that into a giant vaccination hub. And we used to vaccinate up to 5,000 people every day. County of Santa Clara was the first county which received the highest number of vaccinated residents, not only from County of Santa Clara, but people from other counties and other even states were visiting here during that time. So that was extending the boundaries of the hospital and care beyond our typical boundaries where our campuses are, the 3 campuses. That was one approach. And all those locations were enabled by the technology. Like we extended our network over those locations. We extended our EMR over those locations. We extended our care providers, rather deploy them over there that they were available. So we were extending our boundaries and making our system accessible to others. That's one side of that. The other side is that we also have a population that work in agriculture field. Many people, as I mentioned before, they don't even have roof over their head. They were not even capable of traveling to these locations like 49ers Stadium here to get the care or vaccination they needed. In those cases, we had mobile units, and mobile units are, again, the combination of not the physical apparatus, which is like a van or a bus with a staff, but on top of that, there's a technology that they are wireless equipped. They can connect to the same EMR that we are running on premises, and they have the same equipment. So they can not only diagnose the patients, but also document in their EMR. So we have different approaches to make health equitable in the parameters that we can control. And that's how we are doing that.
Yeah, fantastic. This wouldn't be the Quick Hits podcast if we didn't get into the 2 letters that everyone has to talk about in healthcare or anywhere in life. So can you share some successful AI use cases or projects that have been implemented within the County of Santa Clara's health systems.
I've been waiting for Tyler to get there. So, yes, thank you.
And why I'm not surprised, everywhere I turn to, these two letters are there. So AI, like any other organization, is part of our roadmap too. And I believe that where we stand today, we means the whole humanity, or especially the technologists. There's no choice but to adopt, because this is one of the transformation technology that we are lucky enough to have our hands on. Even though I believe this is just the beginning, we are just scratching the surface. So when we generally talk about the AI, everybody talks about the generative AI that we, because of Chat GPT, everybody knows about that. But AI in healthcare is not new. Like the machine learning have been embedded in many systems for a while. And some people wouldn't even know that, well, some of the systems are actually using AI in some way, shape, or form, like they were learning on the data that was being accumulated over a period of time and helping, based on the data, helping to make decisions. But coming to the new wave that has been out there for a year or so, most of the EMRs are enabling themselves, adding workflows which are based on AI. For us, our EMR is Epic Systems, and Epic has partnered with Microsoft to bring in some of the AI workflows. And we have implemented one workflow in our system because we are still at the initial stages. And when we implement AI, I'm going to talk about that in a minute, but we also have a very strong governance over AI. We want to make sure that we are doing the right thing, not because some technology is so popular, or not because our neighbors are doing that, so we have to do it too. Just to give you an example, that when we implement AI, we have to make sure that, because AI solutions mostly are black box solutions, which is that people who implement them do not know what data was used to train those systems. As I was saying earlier, that we serve a very diverse community of 2 million residents here in the county of Santa Clara. So we have to make sure that, knowing our patient population, when we employ AI, it actually truly reflects the data set that we are serving. If the data set is not reflective of your population, then the machine that is making the decisions will not be reflective of your population, and we might end up, our doctors might end up getting to the wrong conclusions that we want to achieve. But still, with that cautious approach, we have our roadmap plan for next 3 years where we'll be enabling multiple workflows with AI. One quick fix that we had that is already in production is to how we can automate some of the message generation. Communication through the patient portal happens in every organization. In our organization, patients also communicate to the care providers via the patient portal, and those messages, when come back, AI is employed to, based on that situation and context, write a message for the provider. But again, that message is not sent to the patient. There is a hard stop that doctor have to read it, and doctor has to approve that message or tweak that message before it goes back to the patient. But still, it has the potential to save about 50 minutes per doctor per day, which is a lot of time. You can squeeze 1 to 2 patients on daily basis because of that time saving, or at least give doctor a break so they can um, prevent themselves from burning out, which is pretty common in the healthcare. So that is one example. Personally, that I'm very excited about in AI in healthcare, because we have been doing these EMRs the way they work for past uh, many years, but especially for the past 20 years. When Kaiser started implementing Epic in 2003, that was the start of proliferation of EMRs in the healthcare industry. And rest is the history, as they will say. But just if you look at the numbers, in 2008, the implementation, the adoption of EMRs was like in 30%, whereas as of 2020, it hit over 90%. So it's been a huge change. And AI will also take its time to be implemented for the guardrails that we have around patient care, around the data that needs to be uh, utilized to train the systems. But coming to the actual core of your question, that what we are doing in that regard, I'm really excited about the ambient clinical voice, because historically, if you see that, if you ever had an opportunity to talk with the doctor, and it's generally a 15 minutes encounter, But in those 50 minutes, doctor pretty much looks at the computer for 10 and hardly 5 minutes at you, if that.
Yep.
So what ambient is going to do, because AI will be listening in the background, so the provider can focus on the patient, have the conversation, and these new EMRs, the old EMRs with new enhancements, make sure that they capture the information correctly and make sure that it is documented in the way that not only it helps with the rest of the steps in the medical encounter, which is diagnosis, but at the end it has to drop a bill, so eventually the organization get paid. So that's where we are going to go. We are working on that. We will have ambient clinical voice or ambient technology that captures the conversation, so the providers can focus more on the patient and less on the technology. And that is next. That is what's coming to us, and I'm pretty much excited about that.
So, Khalid, looking ahead, what is your vision for healthcare IT, and how do you see the role of leaders like yourself evolving and shaping the future of healthcare?
Yeah, one thing that comes to mind right away, it's not related to the technology. It's it's related to actually the business knowledge. I believe that future technology leaders, and a change is already happening, will be savvy enough about the business. They will understand how the business of the healthcare works. What are the challenges from, again, operational and business side? So when they look at the technology and when they wear the hat of the solution provider from technology perspective, they have a deep understanding of the business. I believe historically, people in the technology realm have risen from the technology. They had some role in the, I'm like that too. I'm not a clinician, I was a technologist. But over a period of time, and with my ambitions to rise in the leadership ranks, I actually invested in understanding by doing courses, by talking with other operational leaders and healthcare leaders, care providers to understand how these workflows work. That is a bridge that needs to be crossed, and that cross needs to happen from both ends. And what I mean to say is, in future, ITCIO is already happening, maybe, but I see less than 10% CIOs in the healthcare are actually coming from the care provider experience. Many of them are still technologists. So one thing has to happen. Either the individuals that are coming from the technology side need to understand business very well, or there should be a methodology where the leaders from the operation side or care provider side can be trained to lead the technology. So that is one trend that needs to happen, because the challenges in healthcare are unique, and not all of them could be solved with technology. Having a deeper understanding of business and what are the drivers out there, be it from the payer side or a provider side or even a patient side, that will help. Now comes to the second part of the question, which is that how the future of the healthcare is going to look like. With the advent of AI, especially in the modern form, which is the generative AI, a lot of changes are going to happen. My vision for the healthcare of future is that technology should enable the care providers to focus on patient, not on the technology. Like technology, the ideal implementation of technology, it's a fly on the wall. And that's where with the ambient technology is happening, that at least it can listen. It still has to mature to a certain level, but the start is pretty good right now. So the future healthcare and technology merger is that technology is something that lurks in the shadows, but still takes care of all the processes, from the capturing of the demographic data to the clinical documentation to the dropping of the charges to generation of claims and receiving the payments and completing the whole life cycle. That needs to be done by technology, but as an assistant in the background, not something that you have to make between the care provider and the patient, which is right now. If you every exam room that you go, as I was saying earlier, providers look at the monitor more than the patient. But can we take technology at a place where it is something that is in the background, and the conversation happens between the provider and the patient? That is my dream for the future of the healthcare technology.
Thanks again for listening to Quick Hits, a healthcare technology podcast for healthcare technology professionals. Follow us on Spotify or Apple Podcasts, and don't forget to reach out to us with feedback, suggestions, or even people in the healthcare technology industry you think we should interview. Send an email to quickhits@healthdatamovers.com.